Hello, good afternoon, friends. I am Dr. Rajendran. I am an orthopedic surgeon working in Apollo hospitals in Karaikudi, Tamil Nadu. I'm here to share my views about the management of pain around the time of surgery, before and after that. And if you have any doubts or if you have any concerns about the pain during or before or after surgery, then this is a good time to bring out your fear and we can discuss what might be bothering you. So I have a PowerPoint that I think we can share on the screen right now. And we'll see how it goes. If you have any questions and or if you want me to address any concerns while we are presenting, I encourage you to stop me right there and ask me questions straight away. So that's me, Dr. Rajendran. So what is this about pain and surgery? The surgery is usually done to relieve a pain or to bring about a desired cure, remove something or correct something. It is definitely a painful procedure, but thanks to modern medicine, now we need not experience the pain while the surgery has to happen. The indications of surgery, as far as orthopedics is concerned, the main indication for surgery would be the primary problem with which you present. But if it is for joint replacement, then most likely you are doing this surgery for pain. And if it is surgery on the spine also, most likely it is a surgery that you do to relieve pain. So in these cases, pain is already present before the surgery. We expect the pain to disappear after surgery. And surgery can either cure the problem or just give pain relief. It need not actually cure the problem at all times. And what is pain? Pain is an unpleasant sensation caused by harmful or potentially harmful stimuli. I don't want to go into the details of definition. There are plenty of definitions, but the most gross classification of pain would be either an insidious pain, which means it starts from within the body without any external causes. Usually it is due to infection, degenerative changes like you have osteoarthritis or a low back pain that develops over a period of time, overuse and overwork syndromes that can occur in some muscles, and other medical illnesses that can cause pain, incessant pain. The external causes usually is injury. Most commonly that we come across in the OPD is injury. Apart from that, stings and bites and prolonged pressure. Somebody who has been, drunk and who's been lying on the sidewalk for a day or half a day, they can present with pain in some parts of the body. So, what is pain actually? It is a totally subjective phenomenon. There is no objective pain. Like you cannot compare one person's pain to another person's pain. So, it is what we feel, and it is not something that the doctor can find out by doing a test or by reading from a meter. So, because it is subjective, it also varies from person to person. Because what I feel as painful, somebody might not feel painful. And here we have to address one important concern, that is acute and chronic pain. So pain is actually a protective reflex that is evolved over the time. There are some questions coming up right now, but I think I can address that later because it's not within the scope of my talk today. So pain, we want to understand what pain is and why it has evolved and why it is important, because acute pain is a protective response. It plays a very important protective role. It prevents us from injuring ourselves further, and it tells us that there is a problem in some part of our body. For example, you put your hand on something hot, it tells you it's a pain stimulus, and it tells you that you should remove your hand from there, otherwise your fingers get burned. So this is acute pain, whereas chronic pain is continuing pain with after the initial injury has long past gone. It has little or no protective role. This is like your back pain or the pain you experience after an injury, years or months, years after an injury. It is more a byproduct of the body's pain handling mechanism and the memory effect of pain. There is no protective role here. So we need to understand that acute pain, while is essential for all of us, chronic pain is not. Okay, I'm getting some questions here, so we'll address that a little later because I'll be addressing those answers in my talk. So, what are the factors influencing pain? We usually come across three important categories of factors. One is the physical or physiological factors, the genetic makeup, the fatigue, the drugs that we already are on, the medical conditions that we already have. All these will affect the physical pain. And then we have the social aspect of pain. Cultural upbringing, the attention we receive as children and as adults. Some people complain of pain just to get attention, and they begin to believe at some point that they have pain. That is because that's how the brain works. When you start telling you have pain, and when you start believing you have pain, you actually sense pain, even though there is no pain. There is no stimulus that brings about pain. The previous experience with pain can actually put a lot of character to the pain. For example, if you already had an appendicectomy and if you had a very painful procedure at that time, you are very wary of undergoing any other surgery. You don't want to come under the knife for any other reason. Some people have had a very bad experience with just a injection, and that is what gives them a lifelong fear of needles. And last but not the least, it's the psychological aspect of pain that is also very important. Anxiety heightens pain. Anxiety actually makes you feel more pain than what you normally would, whereas depression actually makes you feel less pain. So, depression is good to feel less pain. Overall, it is not what we are aiming at. There are plenty of other mental conditions where you actually feel more or less pain. And the mental training is also the amount of mental training that you've already undergone, as in your childhood, in your school days, that also puts a lot of character to the pain that you experience. What I'm trying to convey here is, let's say a person gets injured in the war field and during an accident. You would understand that though both the nature of injury is the same in both cases, the person who is in the war field actually feels much less pain because there are some other factors that are influencing what he perceives as pain. So that is what we are coming to now. How do we reduce the pain? This is with regard to around the time of surgery. So if it is chronic pain, we'll have a totally different direction of discussion. So you are going to undergo surgery, and let's say you want to make sure that it is a painless experience. It is not that your painless experience is entirely in the hands of the doctor. There is some part of it where you actually play a vital role, where you actually play an active role in controlling your pain. So, as I said, pain is subjective. So, it is only as intense or unpleasant as you think it is. So, if you boost up your morale and you actually believe that your pain is tolerable, it is much tolerable. So, there are a lot of techniques that will tell you how to control your pain. One of the best techniques is meditation. And this is not just from my mind, or it is not my opinion or the opinion of my colleagues. There are several studies that have actually shown that people who meditate and who are trained to meditate, meditation is actually a science. So people who are actually trained to meditate, they actually experience much less pain. And even if they experience the pain, the amount of unpleasantness or the amount of intensity that they experience is much less when they are trained to meditate and control the pain. And this is scientifically shown that people who actually meditate regularly have increased frontal cortical thicknesses. Now, the amount of frontal cortical thickness is linked to the amount of intelligence we have. Okay, I have a question right here that's stopping me. This is Mr. Dayanath Kurmi, and he is asking, in acute pain or in accidental pain, what is the first aid to start with? Okay, let's say it is an accidental pain. You hit yourself against something and you have pain. The first thing that you do naturally is to immobilize the part, because you hit something and it's caused an injury. Actually, rubbing can reduce the pain, but vigorous rubbing is not actually advised. You can apply ice, or you can just make it still, stop the movement, and limit the injury. That itself will reduce the pain to some extent. I'll come to that part when we talk about the pain management later on. Okay. So this is about meditation. Meditation does play an important part, and you can see the functional MRI pictures in both, where persons who actually undergo meditation, who have been trained in meditation, they experience much less pain. The brain reacts much less to the same amount of pain when you actually train your mind to do it. And the time to learn the technique varies from person to person. So if you are planning to undergo a surgery and you want meditation to be part of your pain management strategy, my recommendation would be to start the meditation class at least a month before undergoing the surgery. And you have a lot of courses available online. The second most important aspect of pain management where you can play an active role is exercise. Believe it or not, people who exercise actually have much less experience of pain. Even though the stimulus of pain may be the same, the experience of pain is much less in people who do regular exercises. And a combination of centrally acting drugs and exercise is actually able to prevent the pain onset, even at the time of surgery. And minor procedures can be done either with just local anesthesia in people who exercise regularly. And once again, we have the pitfalls there. You cannot exercise today and think that the pain will be gone tomorrow, because the exercise requires at least 3 to 4 weeks before the benefits become evident, and hence the need to start early on. Also remember that it should be well paced and in moderation, because you cannot lift a 100 kilo weight in day one. You try doing that and you'll tear off all your muscles. And so it should be well paced and it should be done in moderation. So it is always advisable to take the advice of a trainer, a proper trainer who is trained in giving you the exercise regimes, who can tell you how to progress, because ill advised or over enthusiastic exercise itself can cause more pain. And this is the graph that shows you the optimal amount of exercise that you can do, because exercise and rest go hand in hand. It is not that you can just keep doing exercises and you'll start seeing the results much sooner. No, it doesn't work that way, because exercise works by stimulating the muscles, and the muscles need time to adapt. You're not giving the muscles the time to adapt, then you're actually causing damage to the muscles and nerves. So there is a graph where you don't do exercises, it's bad. You do too much exercise also is bad. So there is a narrow window where you actually feel the benefits, and that is where a good physical trainer comes into effect. Physical therapy, once again, is a very good modality for controlling pain, both before, during, and after surgery. So various modalities are now available with physical therapy. Your physiotherapist will give you laser treatment now, and he's got cryotherapy now, which were not there a couple of years ago. But I'd like to highlight on the most commonly used techniques. The most common of them is interferential therapy, where I think this is available in almost every place where you go for physiotherapy. And it is basically two electrical currents at different pulses. They interfere with each other. The resultant pulse is what is actually delivered to the muscle. The advantage with this technique is it doesn't actually have the impedance of the skin and other tissues, because if you're giving heat therapy or ice cold therapy, okay, there are some questions coming up. I think I'll answer them later. So this is the advantage with this over the heat and cold therapy is that heat or cold actually has to pass through all the tissues in between. So let's say your shoulder deltoid muscle is injured and you want to give the energy only to that muscle. You don't want the skin to get burned when you want to give the heat therapy. You want the heat to reach the muscle, but you don't want it to reach the skin, which is in between the machine and your muscle. So this is where interferential therapy comes in because it doesn't affect the skin, it bypasses the skin and it can penetrate much deeper. And we have shortwave diathermy, that is once again, it's an electromagnetic wave, just like your ultraviolet rays or infrared waves. And this is actually longer wavelengths than infrared, though it's short wave. The delivered energy is actually perceived as heat, and depending upon the wavelength, the degree of penetration varies. And it is useful for superficial to moderately deep structures only, like for your muscles or your joints in the knee and the ankle, but not the hip. And this is about TENS therapy. There is another therapy where you have a portable machine. It stimulates the muscle by stimulating the nerve that goes to the muscle. So this is a novel technique, but it's been around for more than 30 years now. And they say a lot of theories that explain how it works, but it works. That's the important point. Massage therapy has also been proven in a lot of studies. Massage has to be done by a trained therapist so that it is again double-edged because it can either improve your pain or it can worsen your pain. So once again, you have to be careful with whom you go to the massage for. And massage has to be done by a trained person who knows what the massage is for, and it should be done in moderation. You cannot again go for massage therapy for days on end. You need to give a gap in between because too much massage is also harmful. Acupuncture, I'm pretty sure a lot of people know that acupuncture is available in even the remotest areas nowadays. It has actually been well proven and well documented in a lot of scientific studies. The problem is the people who need to be trained need to be really good with acupuncture. Only then it works. It's basically scientifically validated, and the probable mechanism is activation of the sympathetic system, the suppression of the sympathetic system, and also the release of endorphins. These are the two proposed mechanisms, and it has been shown that acupuncture can actually relieve a lot of surgical pain, even in the immediate post-op period. And nowadays we have the needleless techniques available where acupuncture can actually be done without a puncture. So, what options do you have in the post-operative period? The doctor obviously will give you the pills and injections. There is a WHO protocol for this, and I'm sure most doctors follow this. So they will just start with a low dose painkiller, and then they'll step it up depending upon the amount of pain. Now we have the toolbox approach, what we call the toolbox approach, because we don't want you to experience the pain and then step up the injection dose. So for every kind of surgery, we expect a certain amount of pain, and based on that, we will decide the appropriate amount of analgesic. And then, if it is too much, then we'll step down, or if it is too little, then we can step it up. So that's called the toolbox approach. That is more popular nowadays than the ladder approach. We have epidural anesthesia, where they actually leave a catheter in just outside the spinal cord. It's around the spinal cord, but not into the spinal cord. And there's a tube here that continuously infuses the painkiller. So this is what is widely followed nowadays in all joint replacement surgeries. So the patient is pain-free for 2 to 3 days on end. You don't have the pain of surgery at all. But remember, it carries its own risk. There is a risk of infection. Other than that, it's quite safe. And nowadays you have patient-controlled anesthesia. I'm sure most corporate hospitals have this nowadays, where you have a baseline level of analgesic going on. So you have some amount of medications going on without asking for it. so the pain is normally quite less. And then you have a button in your hand that gives you the option to inject yourself with an additional dose of painkiller whenever you have the pain. The safety, the mechanism is such that you cannot go beyond a set limit for that date. So there is a safety inbuilt into it where you cannot give yourself an unlimited amount of drug. So you are quite safe with it. You can bravely go and ask your doctor for this because it is quite safe. And you also have pain patches. I'm sorry, I probably slipped on that slide. There are pain patches that you have where you don't have to take the pill or take the injection. You just take a patch and stick it on your skin, and it delivers a small amount of drug directly through the skin into the capillary vessels, and that goes and relieves your pain. The advantage with this technique is you don't have to take the injection. There is no invasive procedure, or you don't have to take it orally, so it doesn't go through the liver and it doesn't cause you gastritis. And the amount of drug that you give actually is quite less compared to the amount of drug that you have to take orally. So you have patches now. You can these are available widely even in villages nowadays, and because it's a patch, it can be bought wherever you want. So there's no big technology involved here. It's a little expensive as of date, but not as expensive as the other techniques that we showed, the epidural, and compared to the epidural and the PCA, the patch is quite inexpensive. So that is my talk about how you can control your pain during that time. And to conclude, pain is always subjective. Remember, you also play a very important role in the amount of pain that you perceive before and after surgery. So training yourself, disciplining yourself to face that pain, and tell yourself that you're going to see through that pain will actually help you cope with the pain. And it is always you who should dictate the amount of therapy that is required, because I don't know how much pain you have. I can keep on giving incremental doses of morphine or any other drug that I think you might need, but unless you tell me this is enough, this is a tolerable limit of pain you have, I cannot stop. So it is dependent entirely upon you to decide how much painkiller you want. So you do play a very important role in controlling the pain before and after surgery. And that's my concluding remark. And coming to the questions, okay, I'm seeing this question from Vandana Verma. Sometimes we have heard that elderly patients above 65 years are denied knee replacement surgery. Why is it so, and how do these patients get pain relief? Okay, knee replacement surgery is done for two reasons. One is pain relief, and the other is to get them back to moving. So it is not the age that decides whether you, on the basis of on which we deny the surgery, because age is just a number. Even if you are 90, 95, my oldest patient who has undergone a knee replacement is 92 years old, and he's doing quite well because at 92 years he's still riding a bicycle. So that is not, the age is not the basis on which we decide this. It is more of the physical condition and the general condition of the patient. Let's say a patient has got severe knee pain and he's also got stroke. So his right knee is not moving and he's got pain in the knee. Now, doing a knee replacement is not going to alleviate the pain, and it's an overkill, because if it is just pain that you want to control, there are so many other methods of controlling the pain. You can give an injection into the knee, you can give an injection in the spinal cord, or you can go in and do a rhizotomy. What is, you can just cut the nerve that carries the pain from the knee to the brain. So in a patient with stroke who has very little hope of actually reviving the knee, who has very little hope of moving the knee, there's no point in going in and doing the surgery, such a risky surgery and such a costly surgery, and then not moving the limb. So we decide the surgery based on the patient. Two important things that we decide before doing a knee surgery is the patient should be able to move better than he was when you do the knee surgery. If that is assured, then we do the knee surgery, because doing a knee replacement is like changing the tire in the car. It is just a passive component. The active component is your muscle. Unless we are assured that your muscle is going to get back the strength and you're able to move around and you're able to use the muscle properly, there's no point going around and doing a knee replacement. For that matter, any replacement for that matter. So the patients, there are plenty of techniques like what I showed you in the talk. If your meditation or acupuncture doesn't relieve you of pain, you can always ask the doctor to give you a epidural injection or an injection into the knee itself that will relieve the pain. Or if it is, if you think he requires repeated injections, there are actually injections that will kill the nerve and that will relieve the pain permanently. That is reserved for people for whom we expect no improvement in the movement in the muscle. So you can always consult your doctor, but age is not the factor based on which we deny the knee replacement surgery. That I can assure you of. Okay, I am getting another question here by one of Mr. Sunil Mastkar. Could you please advise few useful tips to overcome mild pain of hip and knee? Exercise. My number one go-to would be exercise, sir. Once you do regular exercises, it brings down the hip and knee pain. It improves the muscle strength, and also it improves the ability of the joint itself to move much better. Remember, the degeneration in the hip and knee is not like a machine where you keep moving it more, the machine gets actually worse. It's not like that. In the humans, the bone is always growing. As long as there is life, it is always trying to repair itself. So even if you have hip arthritis or knee arthritis, it is always trying to repair itself. So give it adequate rest for the hip to grow back and then start doing exercises to stimulate it, and the pain actually comes down. It has been shown that even in patients who have had pain for more than a year, if you put them back on a rigorous 3 to 6 month regimen of exercises, they get very good pain relief. Now, this is what we do. What we do is, if any patient comes to us for a knee replacement, we are going to put them on at least 3 months of rigorous physical therapy. I wait for at least 3 months before I go ahead and do the replacement, because I've seen that at least 50% of my patients get away without a replacement when they come actually seeking a replacement. So exercise is my number one go-to. And if exercise doesn't work, combine exercises with something like acupuncture, TENS, physical therapy, or painkillers also. And only if these two fail, then you can go for knee replacement. Of course, if you want performance, like you want to ride the bicycle again, then knee replacement is the number one choice. So that is where it differs. Okay, I'm getting another question here. What can be the best exercises for relieving back pain? Now, this is a tricky question because we should know what is causing the pain. Because there are a number of conditions that can cause back pain. One is the most common that we come across is degenerative pain, that is arthritis in the spine. It is called spondylosis, and that is the number one reason for pain, but that is not the reason for pain for everyone. So first it needs to be evaluated. Do you have a listhesis? Sometimes the spine can slip actually. The bones can slip over each other and they lose stability. When you have an unstable spine, I wouldn't recommend exercise. I would recommend a surgery to fix the spine and stabilize it first, and then go for exercises. But most commonly, the exercise the is recommended for spine is spinal flexion exercises and straight leg raising exercises. These are simple exercises that can be done, and that raise the most common cause of pain in everyone. That is brain. The brain learns to do some, the brain learns to perceive pain, and by doing exercises for that part of the spine, the brain unlearns it. So that part is where the exercise actually relieves pain. You don't need medications, no amount of medications, and no amount of surgery in such patients will relieve the pain. Because a lot of patients who come with back pain and who have undergone failed back surgeries are because we have not identified the site of pain. Most of the time, it is the brain where the pain is perceived by the brain. But the problem in the spine has long corrected itself. But the brain continues to see pain from the spine. The problem is not in the spine, but in the brain. So we need to unlearn the pain that the brain has learned. So any exercise for that should be working good. Okay. I have another question here from one Mr. Siva Mahendra. What are the safety precautions a patient must take while visiting the hospital for undergoing orthopedic surgery during this period of COVID-19? That's a tricky question once again. Anybody could be infected, both the patient or the doctor or any healthcare worker. So if you're going to visit the hospital for a surgery, make sure it is essential. So right now we are not doing elective surgeries. We are not doing knee replacements and hip replacements. These have been suspended till further advice from the government. Some places have restarted them by screening the patients regularly, but the only way we can prevent it is by following universal precautions. Everybody has to wear the mask. Make sure you don't go to places unnecessarily. Make sure you don't spend time with others unnecessarily. Isolation is the only answer we have right now. And everybody needs to get tested, both the patient and the doctor. And once the tests are negative, it's not a guarantee that there is no infection. So even if the tests are negative, we have to be prepared for a scenario where one of them turns positive. So unless like you have a fracture or you have met with an accident and you need to undergo surgery, nobody is going to recommend you to go to surgery right now at this time. Okay, I'm seeing another question here by one Gunjan Dhingra. My husband had microfracture knee surgery 2 years back. If he sits at one place for more than 30 minutes, he faces a lot of difficulty in walking. This is actually osteoarthritis, the stiffness that comes with immobilization is actually due to osteoarthritis. Microfracture is also done for osteoarthritis. It is done to improve the cartilage, but it can only do so much repair. So if you think this is admissible, I would still suggest you try 3 months of exercise. There are a lot of compounds today that you get like glucosamine, and you have type 2 collagen nowadays that is doing wonderful work. You can try those two drugs. They are actually not drugs, they are more of nutritional elements to the cartilage, and they are doing wonderful work. And you can try this for 3 months. And if you have no relief, or if you think you're not satisfied, you can consider giving an injection into the knee joint. You have something called viscosupplementation, where you inject a viscous substance into the knee joint, and it improves the lubrication in the knee joint for some time. And if you think that is solving your problem, fine. If you are still not happy with the results or the outcome, then knee replacement is the option for you. But remember, the natural cartilage is the smoothest substance in the world. So if you're not happy with the cartilage, chances are that you might not be happy with the artificial prosthesis as well. So unless you are really in severe pain, it is not advisable to go for a replacement at this stage. Okay, I am seeing another question by one Mr. Naveen Dhiran. It says, I'm suffering from back pain when sleeping time and morning wake up time. After that, there is no pain, and I need to take medicine. If tablet required means kindly tell some tablets. Okay, this looks more like a rheumatic problem. There are some diseases that will affect the joints specifically, and this is one particular kind of problem that is associated with such diseases. So you have ankylosing spondylosis, you have seronegative arthropathy, you have rheumatoid arthritis, and these are called rheumatic diseases. These actually cause your joints to deteriorate if you don't move them. So it typically has the feature of morning stiffness, where you wake up in the morning for at least half an hour to 1 hour, you feel the joints are stiff, and after that you're fine. This requires medication. You need to see a rheumatologist, you need to undergo blood tests, you may need an MRI, and you need to take medications. This is not a subjective problem. This has got objective valuations for it. You have rheumatoid factor, you have ESR, you have CRP. You can see these values and see if you actually have the problem. And if you actually have the problem, medications are the only way that will cure this problem, and they need to be taken for a long time. And be assured, these medications have been time tested. I know a lot of people who have been taking them for like 40 to 50 years, and they don't have many side effects. So the side effects are acceptable. Only then the medications are given to you. You need to see a rheumatologist. Okay, I am waiting for other questions now. Maybe I may have missed out some questions. So I'm just scrolling back. Okay, I have one question by one Mr. Sanjeev Sharma, and he has asked, in arthritis pain will occur anytime or any part of the body? Well, that depends once again. Arthritis is a broad term that includes both osteoarthritis, the degenerative thing, and rheumatoid arthritis, which is actually an active disease. So it can actually affect any joint in the body technically. But usually in Indians, it is the spine and the knee that is commonly affected. We rarely come across patients where the hand or the wrist is involved in Indian patients. This is more common in the Western population. There are still studies going on to understand why this is so. We don't understand why they have hip arthritis more and we have knee arthritis more. Probably related to the way we sit, the way our culture is, or our genetic makeup. We don't know. But there are a lot of studies going on and there are a lot of theories about it. It can occur anytime or any part of the body. First, we need to differentiate whether it is degenerative arthritis or an active disease, as in rheumatic disease. If it is rheumatic, you need to consult your doctor. There is no other go. If it is degenerative, exercise is the best treatment for you and good nutrition. Remember, smoking alcoholism will cause the cartilages to wear faster. So, if you're chain smoking or if you binge on alcoholism, then it is likely that your joints are taking a spin much earlier than we expect them to. Okay. Okay, I have this question from Mr. Anish Tripathi. It says, what is the newest procedure for total knee replacement? Is minimally invasive good? What is the recovery period after surgery? What is the disadvantage and success ratio? My mother's age is 67. More than the age, I would like to ask how well your mother is. Meaning, was she able to go to the store by herself a year ago? How far is she able to walk? Is she able to walk 5 kilometers a day or 2 kilometers a day? Or is she just able to make it from bed to bar? So these things will determine. And total knee replacement, a lot of newer techniques are coming up. We now have the navigated knee, which I think is superior to minimally invasive because navigation has much less errors. Minimally invasive is just means that you tear much less of the tissue. While it is good, sometimes you may need to actually open up the knee properly, and minimally invasive has got its own merits and demerits. It is beyond the scope of this discussion here. But I would suggest that you first try physical therapy, exercises, you try the other modalities, you consult your doctor about the options you have. You now have high tibial osteotomy where you correct the, sometimes you have a deformity in the knee which is corrected without having to undergo a knee replacement. And there are plenty of doctors nowadays who are coming up with alternatives to knee replacements. You can try them first before going for a knee replacement. And if you are going for a knee replacement, you always have computer navigated knee replacements, which I think are currently cutting edge. And disadvantage to success ratio, there always there is a 20% margin where who are not happy with the knee replacements. So I suggest you try the others before coming to knee replacement. Your doctor should be in the best position to assess it because it is not like you try the non-operative techniques and then go for knee. That's not the case. Once again, we have the toolbox approach here because for some people, knee replacement will be able to give a much better result than taking the other route. Where let's say you have a deformity of 30 degrees, no amount of medication, no amount of exercise, no amount of physical therapy, no amount of acupuncture is going to correct that. It's a mechanical problem that needs to be addressed differently. So you need to address the problem. So your doctor will tell you whether the problem needs a surgical correction or whether you can try conservative methods first. So it is not that you have to exhaust the conservative methods and then go for surgery because if you have a 20-degree, let's say you have a 20-degree deformity, it is easier to correct and the cost of correction will also be much less and the results will be much better than when you have to correct a knee that is 30 to 45-degree deformed. So the earlier we correct these deformities, the better. So in those cases, I would advise to go for a knee replacement much earlier than you would normally go. So it all depends. So you'll have to see the doctor, and because it is on a per case basis, we cannot discuss this broadly. I cannot give you an answer that fits everyone here. Do we have any more questions? Okay, I have a new question here. This is another question by Mr. Chandrajit Kumar. I think I've just answered your question. He says, my mother is 65 years old, suffering from pain for knee joint. Kindly advise medicine or surgery. That I need to see your mother to decide, and I need to see whether what is causing the knee pain, whether it is the deformity, whether it is a mechanical problem, or whether it is the muscle that is causing the pain. So you need to consult your doctor. Okay, I'm coming to the next question by Mr. Shankar. What is the lifetime for artificial cartilage of or knee in terms of function and painless period? Okay, first we don't have artificial cartilage. I believe what you're asking is cartilage transfer or cloned cartilage. We have we have the ACI where you implant the chondrocytes, you implant your own cartilage, you clone your cartilage and then autologous cartilage implant. I think that is what you mean. Usually, since these techniques are new and the patients on whom we apply, we don't know the natural history of outcome in these patients. So usually they go to osteoarthritis, full-blown osteoarthritis over a period of years, which ranges from 2 years to 10 years. So your cartilage life depends on the other factors in the knee, already existing in the knee. Like you're a smoker, your cartilage will live probably for 6 months after transplant. Whereas if the normal cartilage is able to survive for 10 years, there is no reason to believe that your artificial cartilage will also survive for 10 years. So the artificial cartilage doesn't actually differ very much from the natural cartilage, though it is more susceptible to injury. We can expect a similar time frame of life for both the artificial and natural cartilage that you have. And pain doesn't depend upon the cartilage alone. There are a lot of people in whom the X-ray will show you that there is no cartilage and they don't feel pain at all. And there are people in whom the knee looks absolutely normal. There is just a grade 1 chondrocyte, chondromalacia, and they have severe pain. So pain and joint wear do not go hand in hand. Sometimes you have to address the pain more than the joint problem. Some people, I actually, let alone people carry on with their work who have no pain, even though their joints so 25, 30 degrees of deformity. They're able to carry on their activity without any pain. They're not disturbed by the pain. Why bother correcting it? That is the approach we should have, because you are not trying to correct the deformity because the deformity is there. You are trying to correct the deformity because it is either causing pain or it is not letting you do something that you are able to do before. If you are able to do everything that you were able to do before without much pain, there is no idea of going in and correcting something. Okay, I think my 40 minutes is up, and also the questions have stopped coming in. So I'd like to thank you all for joining me, and I think I've had a very wonderful session. I hope you had the same, and I hope to see you again soon. Thank you.